You are breaking. Check your connection, internet connection kindly.
Sorry, let me just pause that and check my connection. Okay, let's try. Are you hearing me well now? Gladys?
Yes, we can hear you now.
Okay.
Take back the presentation.
Yeah, let me put back the presentation.
Thank you. Perfect. Put in the presentation mode. Thank you.
Yes. Yeah,
Okay.
so chronic pain is pain that lasts more than 3 months. In the studies of tissue healing, most of the tissues by 3 months, the healing has happened. So cancer pain is considered to be chronic pain sometimes, especially when it is advanced cancer, because we are not able to cure or healing cannot happen. And it can be acute in the instances where we are able to offer treatment and get remission. So cancer pain by itself, it's pain that is caused by a cancer. So the etiology of the pain is cancer. It is very common. Patients experience pain either from the time of diagnosis. The pain is caused by the illness. The pain can be caused by treatment. So in advanced stages, it's thought that at least more than 60% of patients will experience pain. That's 6 out of 10 patients. So at early stages of the disease, around a third of the patients will experience pain, and usually when they get curative treatment and cure or remission is achieved, the pain goes away. But for patients with advanced cancer, most of the time they will experience pain because there'll be a tumor infiltrating on some body organs. Sometimes treatments like radiotherapy have also been shown to increase inflammation and pain. Dr. Cecily Sanders.
We've lost you a bit, Dr. Nafula.
Describe a
Hi, Daktari. Or is it on my side only?
So, hello?
We have lost you, Daktari.
Gladys,
Yes,
you can hear me?
we can hear now, but we had lost you since you put that slide on.
Sorry, I'm having a bit of challenges with my internet, so please let me know when you are not able to hear. So Dr. Cecily Sanders described the concept of total pain for cancer patients. And total pain looks at pain as an experience that is not just physical, but there is also psychological, social, and spiritual components of pain. So the psychological component of pain, when patients present to us, they come because of physical pain. So they will often come and say, I am having pain, like Mr. Onyango presented with back pain radiating to the lower limbs. That is physical pain. Psychological pain is thought to be the pain that is associated with the illness, with the thoughts and process of adapting to illness. So patients have anxiety over their illness, some have depression, some have fears about the future and uncertainty. Our patient expressed that he has a young wife who is not paying attention to him. He's having erectile dysfunction and is worried about his young wife. So those are manifestations of psychological pain. Are you able to hear?
Yes, we are hearing. We are following.
Okay. All right.
Thank you.
Then spiritual aspects of pain have a lot to do with meaning of life. So when someone is confronted with an illness like cancer, and it's advanced cancer likely to be a terminal illness, they question the meaning of life. So manifestations of spiritual pain include anger towards God. Some patients become religious, and some who are religious stop being religious. So they're trying to find meaning. They're trying to ask themselves, why me? You'll hear sentiments like, I've been serving as a church elder, I've been serving as a deacon, I've been a priest, now I'm sick and I cannot be cured. Why is God punishing me? All that is manifestation of spiritual pain. Then social pain comes in when a patient loses their role in social status, because sometimes cancer is very draining financially. So you find that a man has now become dependent on the wife. If it's a lady, she's now become very dependent. She has to be assisted. So there's the loss of just your role and not understanding what to do. Worries about the future. You just depend activities of daily living. This includes feeding, changing, getting around. So someone loses control and becomes dependent on the people around them, and that really affects how they think about themselves, and it also affects the experience of illness. Now, I'll give you some pain concept came about. Dr. Cicely Sanders was doing research among cancer patients in a hospice. So these were patients who had been given a prognosis of 6 months or less, and she was
You are again breaking.
dying.
You are again breaking, Doc.
Oh, my internet is very bad this afternoon. Just a minute. How about now?
Now you are audible. You can go ahead.
Okay, so if I break, I'll just pause and then continue. Electricity and internet today. So Dr. Sanders was working with the dying cancer patients, those with a prognosis of 6 months or less, and she wanted to understand how they experience their illness. And she was not doing a study on pain. She was doing a study on death and dying and preparing yourself. What do patients go through when they're preparing themselves for death? But then she came up with this concept of total pain, that there's so much apart from the physical pain that patients have to endure, there's so much suffering and so much other aspects of pain that remain unaddressed. And in her studies, the conclusion was, if you only manage the physical pain and you do not assess these other three domains, psychological, spiritual, and social, most of the time you're not actually able to help the patient, because you keep on increasing analgesia, but the pain is not going to go away. Because if someone is questioning God and why they're suffering, as much as you prescribe painkillers, these other emotional aspects of pain actually worsen the physical pain. So not only do we need to assess the physical pain well, but we also need to address these other issues. How is someone taking their illness? I'm 75 years old with a young wife. My children and my wife are not agreeing. They think that my wife wants my brother. I'm having erectile dysfunction. I thought I'm starting all over again, having a new life with my young wife, but now I'm sick and I have an incurable disease. I have prostate cancer. So it is good to consider these things so that when we are giving a treatment plan, we are able to give a holistic plan. Now let's go to pain assessment. Pain is a very subjective experience. So you cannot experience the pain. You cannot even imagine what someone is experiencing when they have pain. Only the person experiencing the pain knows what it is. So pain is further defined as what the patient says it is and happens whenever the patient says it does. So when taking a history, you have to assess properly, and the first rule is just believe the patient. A patient who comes and says they have pain, that patient has pain. Even when the pain is psychological pain needs psychological intervention. So don't just write in your notes and say this patient has psychological pain, then you send them away to come back after 2 weeks. What intervention have you given for that psychological pain? So take a comprehensive history. Then we have standard guidelines for assessing pain, and it's important to use the same assessment tools, and you are able to see if there's any change over time. So this principle applies to both the physical pain, social, psychological, and spiritual pain. When a patient presents in pain, and the patient is screaming in pain, manage the pain first before you start collecting your history or assessing the pain, asking them too many questions and they're in pain. Manage the pain first, and then you will get the patient more relaxed and have a relaxed and comfortable atmosphere for you to be able to assess the patient well. So collect information on the illness. In this case, it is cancer, and any previous treatment that the patient might have received, and then review the medical records that the patient has come with. Remember, some patients get disease progression, some get recurrent. So it is good to assess when a patient has presented with pain and they have a history. Because a patient has cancer does not mean that they cannot get. You do need to take a very comprehensive history. Also collect information. Hello. Okay. Collect information about traditional medicines and other over-the-counter medicines. In Kenya, it is very common for patients to walk into a pharmacy and get some pain medication. So include it in your history. Is the patient taking any medicines? Are they mixing herbal medication and conventional treatment? What about the drugs they're taking? Are the drugs efficient? What is the dosing?
Check again, please. It is still unstable. Sorry for that, members.
So we are having some. Can you hear? Hello. Are
No
you
sound completely. We are so sorry, members. Let's be patient as she sorts out.
Can you hear now?
Yes.
Sorry, I'm so sorry. The internet is quite unstable.
It's okay. We understand.
Yes, I will.
Can believe.
I will repeat the information on this slide. When taking pain history, remember to ask about the medications the patient is taking and where those medications have come from. Did they get them over the counter? Were they prescribed? Are they traditional medicines? Are they leftovers from a relative, from a previous prescription? Then what is their experience with those medicines? So are the pain medications effective? Do they have any adverse effects? These drugs, has the patient taken them previously? Because it is also common for patients with chronic pain to tell you, don't give me morphine, I want tramadol. Don't give me codeine, I want betapine. when taking the history, you will find out what experience the patient has had in the past with pain and pain medications, and then look at the factors that alleviate or exacerbate their pain. And remember, we've talked about other domains of pain. There are patients whose pain increases when they see certain relatives. So your patient is very calm and very okay, and their pain is controlled, and as soon as their spouse walks in, then the pain goes from 0 to 10. So evaluate what these factors could be and the meaning behind some of this behavior that the patient exhibits when they're having pain. So when talking about pain, I look at the PQRST model, where we look at the things about the pain. So precipitating and relieving factors is P. The quality of the pain is Q. That is where the patient will tell you, is it dull in nature? Is it shooting? Then we have the radiation of the pain. Where does it go? And that helps you to decide what is causing the pain. Then, what is the site and severity of the pain? This is where we use our pain assessment. And then T is for timing and previous treatment. These are some scales that we use for pain. The one on the list is a bubble rating scale that just worst possible pain, and the patient tells you where their pain is. We can also ask them if the pain is mild, moderate, or severe, depending on their level of knowledge. And on the right, we have the numerical rating scale that we use to rate pain from 0 to 10, where 0 is no pain, 1 to 3 is mild, 4 to 6 is moderate, and 7 to 10 is severe. The FESES scale or Wong-Baker scale is very useful for children above 3 years and illiterate adults, so they are able to pick for us the face that corresponds to their pain. Now, remember, these tools are for physical pain only. So after you've assessed the physical pain, then you go now to check on the other domains that we've talked about. So we are diving into pain management now. And remember, we are dealing with cancer pain. So first, factors to consider is the underlying cause of the pain. So when a patient has cancer, they've come with pain, the first question to ask yourself, is this cancer curable, yes or no? If the cancer is curable, what is the treatment plan? So how long are we likely to put this patient on pain medication, and what plan do we have of weaning them off analgesics? If the cancer is not curable, what is the plan for managing the physical pain, and then what other support does the patient need so that we are able to provide holistic care? What is the patient's age? Patients above 65 tend to have comorbidities, and reducing renal
Sorry, Doc, we have lost you again.
and hepatic
So
function,
sorry.
so we are just medicating. Yeah. 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 I'm saying they are medicated because they have comorbidities and down of function. So,
Dr. Nafula,
hello.
we have lost you again. Sorry for that.
Can you hear me now?
Yes, just continue. We hear.
Yes. So patients above the age of 65, we need to adjust medications, and generally we start at half the dose, for example, of opioids, because they have a slowing down of renal function and hepatic functions. And we also have to consider which comorbidities does the patient have. Are they diabetic, hypertensive? Do they have kidney failure? Do they have organ failure? And then what are the current medications they're using and the drug interactions or toxicities? And just to mention a few, patients who are on blood thinners or patients who are on steroids, we need to be very careful about bleeding, and therefore we need to consider which NSAIDs we are going to prescribe and for how long. Patients who are hypertensive could be on ACE inhibitors that alter their potassium levels. So before you prescribe analgesics, it is good to have the baseline renal, hepatic, and blood count, total blood count, just to know, because some of these medications, like NSAIDs especially, they are going to cause bleeding. So if a patient has thrombocytopenia, then they are on steroids, are you really going to choose to add them an NSAID? And if so, maybe because they have bone pain and it's indicated, how are you going to monitor when they're on the NSAIDs? Then what is the current intervention the patient is getting? Are they on chemotherapy, radiotherapy? Are they due for any surgeries or surgical interventions? What other allergies might the patient have? Any anticipated adverse effects? Sometimes we have patients who have cancer and they're also pregnant. So for pregnancy and lactation, which is your choice of analgesics? And do you focus on treating the mother of her cancer, or do you focus on carrying the pregnancy to term? Then there's alcohol and opioid use. You also have to consider that. And we've mentioned again the social issues you also have to consider, even affordability of the medication. If you're going to prescribe 5 drugs for pain, is your patient going to afford those medications? Are they available? So for analgesics, we like to use the lowest effective dose of a drug, and we start with oral, which is the simplest route, because the patients are likely to be on analgesics for a long time. Cancer pain is not pain that we treat for weeks, 2 weeks. It's pain that we treat for months to years. So we want to use oral medication because it is sustainable. It's easy for the patients to use the medication. Use a single agent before you add others. So emphasis here is on pain assessment. If you assess your pain well, you'll be able to pick your painkiller properly so that you're not prescribing something. Consider what to do with breakthrough pain. Then we need to prevent and treat expected adverse effects. If we are going to prescribe morphine and it's going to cause constipation, let us prescribe a laxative. Nausea, prescribe an antiemetic. Use a stepwise approach, which is the WHO analgesic ladder. And then there's a lot of variabilities among our patients. So you need to consider the factors around the patient. So this is an elderly patient, this is an alcoholic, this is a pregnant lady, this is a patient who has been exposed to opioids before, this is a patient who has a cancer recurrence, this is a patient with a poor prognosis. You have to individualize the care. It is not the same across the board. So the WHO principles are 3, and the first one is by the mouth. So we've already mentioned that we like to use the oral route because it is sustainable, it's easy for patients and their family, and you can keep a track on how the patient is taking their medication. The next, Kenyan prescriptions tell patients take 1 tablet 3 times in a day. So sometimes our patients take a tablet at breakfast, which is 8 in the morning, at lunch, which is 1 p.m., and then at dinner, which is 9 p.m. And that medication was supposed to be taken 8 hourly. So when we are giving analgesics, especially for cancer pain, because the aim is to relieve the pain, the patient needs to take the medication by the clock. So we time it. If it's 8 hourly, let us count. We ask the patient 8 hourly, the best is to take at 6 in the morning, at 2 p.m. and at 10 p.m. So let the patient take medications at the specific hours, because when the pain is not responding to the prescribed analgesics, you're actually able to titrate it better, or you are able to switch analgesics. But if the patient is not taking as per the clock or per the hours, sometimes we increase the dose when the problem is just in the frequency of how the medication is being taken. Then by the ladder is the WHO ladder, which I'm going to project next. And we will only consider the ladder in adults for this presentation. Later, we'll probably have a presentation for pediatric pain management. So for adults, the ladder has 3 steps. There's step 1, which is non-opioids for mild pain, and this is where our NSAIDs fall. Then step 2 is for moderate pain, which is weak opioids, and step 3 for severe pain, which we use strong opioids. Now, this ladder was developed in 1980 for management of cancer pain specifically. After the research that Dr. Sanders did, and there was more research by Dr. Kubler-Ross, experts of WHO sat down and prepared this ladder. And up to now, we can confirm that when we use these principles, at least 80% of patients get pain relief. The other 20%, there are many other factors that may be making the pain complex or hard to manage. Now, I'll spend a little time on this ladder because there are a few things that I would like the audience to take home. So first, this ladder is not a stepwise ladder. So it's not like a normal ladder where you have to take one step, get to the next, and then the next. This ladder, it's called a ladder. I'm not sure why. Maybe I'll find out. But it has 3 steps. So you start the step where the patient is. If a patient has come with severe cancer pain, you start with a strong opioid. You don't start with paracetamol, then you go to tramadol, then you come to morphine. So that is the first thing. You start at the point of the ladder where the patient's pain is. There is room to step down. Remember, some cancer patients are going to be treated and they're going to get remission. So the patient came with severe pain, we've started them on a strong opioid. How do we get them off the opioid? We go down the ladder. Even when the patient's pain improves, we go down the ladder. There is room to go down, there is room to go up. Then step 2 and 3 has opioids, weak opioids and strong opioids. Opioids work on the same receptors in the central nervous system. So there is no point combining step 2 and 3. You do not take tramadol and morphine and give it to the same patient. They're going to work on the same receptor. So we do not know which of the 2 opioids will actually manage the patient's pain. So make a decision. And when the patient, sometimes you ask them how their pain is, and then on the numeric scale, they can tell you it is between 6 and 7. So 6 is moderate pain and 7 is severe pain. How do you decide where to go? Ask them additional questions. A patient with severe pain is not going to be sleeping at night, is not going to be mobile. This patient might not be eating. So the pain really interferes with a lot of their activities. The one with moderate pain, there are some activities that the patient is able to take part in. So decide whether it is moderate or severe pain and choose the appropriate opioid. Now, each of these 3 steps has adjuvants. Adjuvants are medications that are not primarily painkillers, but they work on pain pathways, and they're very useful when we have mixed pain or when we have neuropathic pain. So these are anticonvulsants, antidepressants, muscle relaxants, steroids. They are adjuvants. You can use them at any step of the ladder. Now, at step 2 and 3, moderate and severe pain, you can also give an NSAID. So we don't combine 2 opioids, but we can combine an opioid and an NSAID. And sometimes we even have preparations that have already combined paracetamol and a weak opioid. To wind up on this slide, when giving pain medication, communicate with the patient what you're prescribing and why. When you give a patient an antidepressant and you have not told them that I'm giving you amitriptyline, I'm giving you fluoxetine for pain, I'm not giving it to you because you're depressed. We live in a digital era, and the first thing patients do is to go and Google, I've been given amitriptyline, I've been given pregabalin, and I'm going to look what are the side effects and what is this medication for. So it is common for the patient to come back and say, I'm not depressed and the doctor gave me antidepressants. Or they start asking themselves, does the doctor think that I am depressed? Why have they given me these medications? So it is important to explain to them that these medications have an effect on the pain pathway, and opioids alone have been proven not to work on some types of pain. When a patient has bone pain or neuropathic pain, no matter how much you increase the dose of opioids, the pain will not be relieved completely. They'll only relieve maybe 50% of the pain. So we need to use multimodal analgesics, and the patient needs to understand why we are prescribing the medication, how long we are prescribing the medication for, and if there are any special instructions, for example, storage of morphine, handling of opioids, you need to give those instructions. So I'm going into guidelines for using opioids. NSAIDs, I think we are not very worried about NSAIDs because the instructions are a bit clear. But when we use opioids, especially for cancer pain, there are very many myths surrounding opioids. And one of them is that morphine is given to dying patients. And that myth also, patients have had it. When you prescribe morphine, they'll tell you, sijafika hapo, I'm not at that stage of being given morphine. And some of the relatives will raise concerns that we do not want morphine. So first, the oral route is what is preferred, and it is important to know how to dose the opioids, how to titrate them, and even how the opioids work so that you're able to counsel the patient why you're prescribing morphine for them, and that morphine is not equivalent to end of life. It doesn't mean if we are giving you an opioid, you're dying tomorrow. We are giving you the opioid because it is the best medication to handle your pain. And remember, we said we are trying as much as possible to use a single agent to manage pain. So if the patient has severe pain, then we'll go for a single agent, which is a strong opioid that will sort out their pain, instead of having to go on very high doses of paracetamol, maybe high doses of a weak opioid. So this medication should be used continuously and not when necessary. In the cancer world, PRN means patient receives nothing. So avoid prescribing analgesics PRN for cancer pain. Prescribe them continuously for as long as the patient has pain. So start with immediate release formulations because they will relieve the patient's pain within a short time. So immediate release formulations include morphine syrup, injectable opioids like morphine injections. Tramadol has an immediate release and a sustained release. So start with the immediate release. After the pain is controlled is when we now switch to a sustained release tablet or things like fentanyl patches. So once the pain is controlled, then we can go to things that are taking forever to reach their half-life. So if a patient has more than 2 episodes of breakthrough pain, we increase the regular dose of their opioids by 50%. So breakthrough pain means I took morphine at 6 a.m. The next dose is at 10 a.m. It is 8 a.m. and I'm feeling pain. So again, for breakthrough pain, we want to see what is causing that breakthrough pain. Is it a procedure? Is it that the patient is developing tolerance? Is it near the dose? So when we give opioids in the palliative unit, we give patients their personal medication chart to take home, and we explain to them how to take the morphine. We explain to them what breakthrough pain is, and we ask them to look at the pattern of when the breakthrough pain comes and document it. So when they come to clinic, what is very common, you find that they get breakthrough pain close to the end of the dose, so closer to the next dose, or sometimes there's a procedure or they've just forgotten. So I was to get my medication at 10 a.m., then I start to experience pain at 11 a.m. because I've missed a dose. Give laxatives to prevent constipation and antiemetics to prevent nausea or vomiting. So weak opioids in our market, we have codeine, which has not been in circulation for a very long time. So what we have is dihydrocodeine, and we start at a dose of 30 milligrams for adults, 8 hourly, and a maximum dose of 240 milligrams in 24 hours, which gives us that 60 milligrams QID. That is the maximum dose. When you get to that dose, you have to switch to a stronger analgesic. Tramadol has immediate release, 50 to 100 milligrams, which can be given TDS to QID with a maximum of 400. But there's also a sustained release tablet that is taken once a day, which comes as 100 milligrams, and the maximum is 300 milligrams in a day. For strong opioids, we have morphine and fentanyl. And for morphine, we have syrup and tablets, which are immediate release. So the dosing has a lot of details, and I'll try to go through them. Whatever is not clear, we can clarify during the Q&A. So the starting dose is 10 milligrams per dose every 4 hours. And we give a double dose at bedtime, especially when the patient is going home. We ask them to take a double dose. Researchers have shown it's not that the 20 milligrams will relieve their pain faster than the 10 milligrams, but it causes more drowsiness. So the patient is able to sleep through the night and get their next dose in the morning. Because if we are to count 4 hourly, at 10 p.m., then someone will have to wake up at 2 a.m. and wake up at 6 a.m. So it's a burden on the caregivers. There is no maximum dose for morphine. The maximum dose is the one that is tolerated by the patient and relieves the pain. But remember, we have toxic doses. So we start at 10 milligrams, and then we increase by 50% when there is breakthrough pain until we reach a dose that manages the patient's pain. And I can proudly say in the 8 years that I have been prescribing morphine, I have not seen a patient who is using more than 30 milligrams per hourly. And the ones who are using 30 milligrams is very, very few, like 1%. And most of the time they have many, many other issues going on that are making it hard to control the pain. So patients will develop tolerance within 24 to 48 hours. And the first sign of that is that the drowsiness reduces. So if they're experiencing breakthrough pain, then we increase the dose. So I would still like to emphasize the need to give analgesics by the clock, especially opioids. Because when a patient is taking at regular intervals, it becomes very easy. When you want to switch them now to the sustained release tablet, you can be able to calculate that this is the amount of morphine syrup that the patient is using in 24 hours, and you divide that into 2 doses for them to take 12 hourly. Currently, the sustained release tablets are out of circulation in our market, but when they're there, they come in doses of 10 milligrams, 30, and 60. Then for cachexic patients, some cancer patients are very cachexic. When you give them 10 milligrams, it might be too much for them, so it might cause a lot of side effects. For those patients, try and calculate the exact dose of morphine they need, which will be 1 milligram per kg per day, and you will divide that into 6 doses. That will give you the dose for every 4 hours. For injection, we use 0.5 milligrams per kg per day, and we divide it in 3 doses, and it can be given as IV, IM, or subcutaneous. So again, for most patients, the starting dose is 10 milligrams every 8 hours. I do not know if I have on fentanyl, I don't. But for your information, we have fentanyl patches also in the market, but fentanyl patches are not to be given for acute cancer pain. The patient who is presenting in pain, give them morphine first until you control their pain. Then once the pain is controlled, we can switch to the fentanyl patch, which we change after 72 hours. And we have opioid conversion charts. So again, we look at the chart to see how much morphine the patient has been getting in a day, and what is the analgesic dose, the equivalent analgesic dose for a fentanyl patch. So when we give opioids, sometimes overdoses can happen, and patients will have symptoms which include difficulty in breathing, unconsciousness, or pinpoint pupils. Now, remember, some of these symptoms are also symptoms of end of life. So you need to differentiate between a patient who is in end of life and a patient who has had an opioid overdose. And of course, you start by just taking a history, understanding how much opioids they've been exposed to and previous history of opioid use. Are they opioid naive? Have they been exposed before? And naloxone is the opioid antagonist that we use. And what it does is to displace the opioid from the receptor. And typically we give 0.4 to 2 milligrams and repeat every 2 to 3 minutes until the symptoms wear off. So if it is not opioid overdose, no matter how much naloxone you give, these symptoms will not go away. So you need to do a proper assessment before you say that the patient is having an opioid overdose. And respiratory depression is one of the side effects of opioids. And we've talked about the starting dose, and sometimes patients are used to taking 10 mLs of a syrup or 5 mLs. So we can give them our morphine syrup, which has 10 milligrams per ml, and the patient goes and takes 5 mLs or 10 mLs, and they're opioid naive. So that's already a very high dose for an opioid naive patient. We might need to give them naloxone. But now remember, once you give naloxone, it's going to displace the opioid. So that means the pain that made the patient take the opioid is going to come. So you need an alternative way of managing the pain after you give naloxone. Before I move from that slide, also, if the patient is terminal, they are presenting with cancer in the terminal phase, and they're having severe pain, because pain also increases towards end of life. It is very important to communicate the prognosis with the patient and the family before you initiate morphine. Because if the patient initiates morphine to manage their pain, part of being in end of life is also just being drowsy and unresponsive. Sometimes they blame it on morphine and they say that is the one that killed the patient. Yet the patient was already having advanced disease and was in the terminal phase of illness. Next is adverse effects. Gladys, you can hear me? Okay,
Yes,
I can see a thumbs up. Yes.
Yes, we are hearing you, Doctor.
Yes,
Continue.
so opioids come with a lot of side effects, and some are more common with other opioids than others, and one of them is vomiting. We have constipation, drowsiness, confusion, and respiratory depression, depending on which opioid and which dose. Now, the first sign of opioid tolerance, and opioid tolerance is a normal thing that happens, is when the drowsiness goes away. We have many patients on morphine who are functioning very well. So when the patient is given morphine or a strong opioid, even DF-118 sometimes causes drowsiness. Within the first 2 days, the patient will be very sleepy. By day 3, day 4, the drowsiness starts to wear off. So that is tolerance and it is normal. So in case the pain increases, it doesn't mean that the patient has become addicted or their disease is becoming worse. They have developed tolerance. And when tolerance develops, we need to increase the dose to be able now to manage pain. I mentioned adjuvants. And now I'll go back to our slide of total pain for non-pharmacological management. So after giving you a very good prescription of tramadol and amitriptyline and Placil, maybe with an NSAID, come back and look at the other factors. What kind of support does the patient need? A lot of cancer patients have been laid off from their work because they cannot go to work. They are at home and their families sometimes also isolate them and start to kill them socially. Killing here is in quotes. So the family takes over the patient's responsibilities and patient's decision, and the patient is not involved in anything. So all they do is to be sick, to be brought to clinic, and to go back home. So these are some of the things we consider after we've sorted out the physical pain. Now we come to understand, what does the patient think is causing their illness? If your patient believes that they've been bewitched, no matter how much morphine you prescribe for them, they will still have pain because they believe they've been bewitched. So you need to explore those factors. What does the patient think is causing their illness? What do they understand about having cancer? What do they think has caused their cancer? What is their experience with treatment? What kind of support do they have at home, in the community, in their religious groups? And then spiritually, are they blaming God for being sick? And how can we assist them? Because part of this care involves helping the patient to accept their illness and then to set some goals for themselves. So some of these goals could include living a day at a time. It could include just being comfortable to talk about your anxieties. Because we have patients whose families come to ask us, does he or she have a will? the family is concerned. We don't know where their property is. So how do we make patients comfortable to have such engagements and discussions and with their families? And also, how do we make the family comfortable to talk about issues that they might need to resolve with the patient? So as we take care of the physical pain, remember to take care of the psychological, spiritual, and social pain. And when you identify, it depends on your role with the patient. You could be a doctor, you could be a nurse, a psychologist, a social worker. Once you identify the aspect of pain that the patient has, as we are prescribing the medication, we refer them for the appropriate intervention. I am not trained as a counselor, and I have no idea where to start to help a patient to deal with their psychological problems. So the best I can do is to identify that this patient has psychological issues and refer them to the psychologist in order for them to be assisted. This patient has spiritual pain. Can we refer them to a trained clinical chaplain to help them deal with their existential issues, to help them do some advanced care planning, to help them talk about death and prepare for death if the disease is very advanced? Do we have a social worker who can help us to understand the social structure of the patient and how we can support this patient as we are sending them back home with a prescription of analgesics? So we'll go back to our case. Just to refresh for those who joined in late, I will go back to the beginning so that we see if Gladys, you can check the chat for the answers.
Yes.
Yeah.
Thank you.
So,
Thank you very much, Doctor.
Yes. Mr. Onyango is 75 years and he presents to your office with severe lower back pain radiating to the lower limbs. He rates that pain as 10 over 10. It's very bad at night. It's burning in pins and pricks on his legs. And he has metastatic cancer of the prostate. He had a prostatectomy, has been on hormonal therapy, has received radiotherapy 2 weeks ago. And his current prescription is tramadol, 100 milligrams sustained release, Plasil, and paracetamol with no improvement. His first wife died 7 years ago. Now he has a young wife who is 30 years with a 2-year-old son whom they share. And part of his concerns is that he has erectile dysfunction since the surgery. And so the wife is not concerned about his welfare. She's just not there. And he has 3 adult children, 2 daughters and a son who do not get along with the young wife and think that she's a gold digger who is hastening their father's deterioration. So kindly type in the chat or the Q&A what types of pain you think Mr. Onyango is experiencing, what you would do about his pain assessment, and anything you would do differently about his pain management, not just the prescription, but the pain management. So we'll give you about 5 minutes as Gladys reads through the answers, and then we'll move to the Q&A session. Thank you.
Thank you, Daktari, for that wonderful, very insightful presentation. It was really intense and a lot of insights. I think we can continue with the questions, which are not many. And just to bring you on, we were more than 700 people on board. That is a very good attendance. Thank you so much for attending, and don't log out until we discuss Mr. Onyango's case. As they continue typing, there's somebody who asks about surgical. Anonymous person, can some of surgical procedures be part of pain management?
Yes.
That is one of the questions.
Yes, surgical procedures. Yes, surgical procedures are used to manage pain. For example, some cancer patients present with tumors that are disfiguring, like osteosarcoma, rhabdomyosarcoma. These tumors cause a lot of pain that without a surgical intervention, there's no amount of analgesia that is going to take the pain away. So there's a role for palliative surgery. Sometimes we've had patients going for excision of masses. not to offer cure, but to palliate, because once the mass is removed or the limb is amputated, then the patient gets pain relief and we are able to wean them off analgesic.
Thank you, Dr. Nafula. I think you continue putting your questions on the chat. Others are compliments, like Bingeziki. Bingeziki is saying it's a simple presentation using understandable vocabulary. Thanks a lot. Thank you very much, Bingeziki. I don't understand whether Franklin made this was a question, how to control pain intensity in patients with cancer.
Okay.
It's not clear. It's not clear whether it's a question, but you can say something about
I can comment. Yes.
Yes.
Pain intensity. So, okay, my understanding of intensity of pain is about the severity. So the patient will rate their pain on a scale. It's mild, moderate, or severe. So reduction of the pain intensity starts with you identifying the type of pain and the severity, and then giving the appropriate medication. So remember, we said for pain assessment, you use the same scale for the same patient every time. So if today I said my pain is 10/10, you start me on morphine. When you come tomorrow, you'll ask me, how is the pain today? So I'll either tell you it's 10/10 or now it has gone to 5/10. That's how we tell whether our interventions are helping. And then we can be able to add on to the treatment or change the treatment altogether, because the aim is actually to get pain relief.
Sure. Thank you. Thank you very much,
Giving
Dr.
answers? Are we giving answers about Mr. Onyango, what we would do about his pain, what we could change about his pain?
Yeah, there are some answers which are coming up. Where can one get morphine powder in Nairobi? That is Mutuma.
Morphine powder. So, first of all, morphine powder is only sold to institutions. There's a supply chain for opioids. So let me answer assuming that this is an institution. So government institutions are getting morphine powder from KEMSA. And we also have private distributors like Meds who are supplying or are licensed to supply the morphine powder. But the institution needs to be licensed to reconstitute opioids. But the government system, the morphine powder comes to KNH, it's reconstituted into morphine syrup and then distributed through the Kenya Hospices and Palliative Care Association to other government facilities.
Thank you. Thank you, Daktari. Other participants are asking about CPD. I don't know whether research representative is still with us. Maybe this is right answered by them, but I usually think they usually provide CPD for both doctors and nurses.
Yes. They provide CPDs. I think the CPD portal, if the CME has been uploaded there, like now our CPD portal for doctors changed, but you should be able to get a token to be able to claim. If you are not able to, the email is knhresearch@gmail.com. And again, the presentation is going to be uploaded on our KNH YouTube page and the KNH website. You could still use those channels in case you are not able to get the CPD points. And again, we are having this pain management series. We'll be having webinars every quarter. So if you log in and you've not received CPD points for the last presentation, we can be able to follow up for you.
Thank you. Thank you, Daktari, for that reassurance. Somebody else is also asking where they can access the presentation. Is it also going to be put in the YouTube or the website?
Yeah, within a week, it's going to be uploaded to the KNH website and the YouTube channel.
Okay. Thank you very much. There is people are now responding to Mr. Onyango. There is Maureen Mutinda. For the case of study, emotional pain needs counseling, into brackets, him and his family. That is all what she has said. Dennis Kirui, how can someone with breast cancer in chronic pain but he refuses to go for medication be managed? I think if a patient refuses to go for treatment, how can they manage that? And he has pain.
Remember, we've talked about the other aspects of pain. So you need to assess the reasons behind the patient not managed for their pain. What is the psychological component of the issues, or what are the psychological issues around the patient? Because a lot of it could be just a lack of knowledge. Yeah, so as we said, there are many myths around cancer. So you might really want to understand what the patient thinks is causing their illness, and that could be the reason why they do not want treatment.
Sure. Thank you very much. Janet Mbuyuka was asking where we are writing the answers, just where you have written that question. Right there, right there, the answer. Respond to Mr. Onyango. Eugene Kibwana, is pens and TENS being used in Kenya for pain management?
I don't know what PENS is, but I know TENS is a physiotherapy intervention, and yes, it's being used. There is room to refer patients for physiotherapy as well.
Thank you. Raphael is asking, great, is giving a complimentary, great presentation, Dr. Esther. Looking forward to a pediatric version soon.
Yes, we definitely will do pediatric pain management as part of this series.
Okay, someone anonymous is commenting, suppose a patient is in so much pain, that is 10/10, in addition to the cancer being terminal and wants to die, will that be granted?
They wish to die because of pain. I would start by managing the pain, and euthanasia is illegal in Kenya. So if you grant that wish, that is murder and you go to jail. So euthanasia is a subject for a different discussion, but generally try and assess the pain well and manage the pain. And then once the pain has been relieved, ask the patient whether they still want to die. Most of the time, they'll tell you it was just the pain.
Sure, thank you, Daktari. I think the other questions are repeated. If a patient indicates there is no improvement on the use of morphine, what would be the best to do?
If they do not want to use morphine,
yeah.
So if they don't want to use morphine, what we do is first to educate them on the pharmacology of opioids and then find out. Some patients have a very severe constipation, and we might actually want to manage the constipation very well. And if not, there's an option of switching to fentanyl patch or a different opioid with a different side effect profile. And Gladys, my computer is about to go off. We are having a blackout today. So let's see if we can take the final question.
Let me read just two. Mr. Onyango has total pain. He needs to be on step 2 management, moderate pain, and counseling. I think that one, what do you have to say about that?
Yes,
is
so
moderate?
Already, okay, he rated his pain as severe. So if we choose to maintain him, remember this is complex pain because he has the nociceptive pain, then there's a neuropathic, and again, he has metastasis to the spine and his post-radiotherapy. So we would go to step 3 first to relieve his pain because the tramadol was not working. So we would switch him to morphine first and maybe add an adjuvant, and then now explore the other social and psychological problems which could be contributing to the pain.
Okay, thank you very much. There is another interesting one before your laptop dies. There is a new product.
Yeah, in case it dies, just understand. We just
Okay,
continue
fine.
until our time
Okay,
is
I'll
done.
continue.
Yeah.
There is a new product currently in the market called